Good afternoon, everyone, to the Department of Medicine Grand Rounds. My name is Michael Ho. I will be your host for this 5th annual Department of Medicine Shark Tank Finalist competition. We will have 5 exciting projects to see today. So this is the agenda for today. I'll make some brief introductions, provide an overview of the Shark Tank program and the history of prior winners. Then the finalists, the 5 finalists will give their presentations. These were pre-recorded. And then after each presentation, the sharks will ask questions of the project team, and then we'll have a presentation from our winner from last year, and then while the judges go to their deliberations, and then we'll announce the winner at the end. The speakers don't have any disclosures. The goal of the Department of Medicine Quality and Safety Program is to promote a culture of patient safety, quality, and systems innovation among our Department of Medicine faculty, staff, and trainees in order to deliver patient-centered and high-value care. And the goal of the Shark Tank program is really for us to support QI projects aimed at improving high-value care. So this is just a highlight of prior winners. This was our first Shark Tank winner, reducing inappropriate PICC line usage. The intervention comprised of provider education, an EPIC order set, nursing education, and a vascular access team. And this project led to a reduction in cost savings and decreased cost per PICC line, as well as a reduction in use of PICC lines over time. The next project was the second year's winner was a smoking cessation project beyond ABS. And in this project, they used a standardized ancillary support and physician workflow process that was able to reduce the rates of smoking cessation after an initial patient visit, and some of this was sustained over time as well. And this was done at 4 clinics in the outpatient setting. And then the third project was the ICU Liberation Project, the A to F bundle. This was a project that standardized ICU protocols and care, and incorporating an EPIC flow sheet. And then there were real-time daily reports. And this intervention reduced the number of ventilator days from 7.3 to 4.9, and also reduced the number of ICU stays. So as you can see, these projects have made a significant impact in terms of improving the care that we deliver to our patients. So this is the process for today's presentations. We'll play a video, a 3-minute video for each of the presentations. Then we'll have a live Q&A where one of the sharks will ask the team questions. And then we'll have an audience poll for the audience to rank the projects. And then the sharks will deliberate after that. And again, the winner will be announced at that point in time, and they'll receive support from the quality and safety team to help move their project forward over this next academic year. So these are our illustrious judges. As you can see, we have Dr. Berry from the VA, we have Drs. Kumbler and Glasheen from the university, we have Drs. Havernack and Hussein from Denver Health, we have Drs. Lin, Schwartz, and Weiler from university, Dr. McKenzie from Denver Health, and then Dr. Miller from the VA. So again, we have a panel of distinguished judges that will look at these presentations, and then we'll deliberate afterwards. And so the first project will be given by Lorna Allen, and this is the Vectors project.
Thank you for having me. My name is Lorna Allen. The title of my project is Vectors, Vancomycin Errors Corrected Through Optimizing OPAT Medication Reconciliation and AVS Standardization. OPAT stands for Outpatient Parenteral Antimicrobial Therapy. It's a safety program here at UCH where we monitor all patients discharging from the hospital on IV antibiotics. One inspiration for this project was a sentinel event in which a patient was discharged to a skilled nursing facility on IV vancomycin. The dose was transcribed incorrectly onto the DC med list, so the patient ultimately received 3 times the recommended dose. This resulted in an acute kidney injury and an 11-day readmission to our hospital. Review of 6 months of OPAT discharges shows that 32% of the time, vancomycin is omitted from the DC med list or listed inaccurately, and 31% of the time, OPAT orders are not on the AVS. This is particularly important for our vulnerable patients who discharge to nursing homes, as the AVS is what they frequently use to deliver care to our patients. Root cause analysis shows that lack of a standardized workflow, as well as the current demand for involvement from 5 separate teams, contributes to opportunities for error throughout this process, as you can see here. The primary aim of my project would be to increase the accuracy of IV vancomycin on the DC med list from 68 to 90% and OPAT orders on the AVS from 69 to 90% in 1 year. My intervention is an EPIC enhancement, which would create an OPAT specific note. It would serve as a live document and would automatically pull onto the AVS below the DC med list through a smart link. This would negate the need to cut and paste these orders, which is what's currently happening. It could be updated as recommendations change from pharmacy and easily referenced by all the teams involved. My ask would be for assistance in project management, visibility, and data analysis. And while the focus of this project is on vancomycin, the intervention would positively impact all patients discharging to the OPAT program here at UCH. You can see here that OPAT volumes doubled in 5 years, and so this intervention would reach about 1,000 patients a year. It addresses multiple domains of quality care and would improve high-value care through reduced errors and cost and increased transparency. It would eliminate 4 steps from the current workflow and relieve the primary team of having to accurately self-select the dose duration and frequency of the drug. Lastly, orders for this high-risk drug would be consistently accurate and visible. I hope I've provided a compelling argument that change is needed here. So with that, I say let's take a bite out of this low-hanging fruit to improve care for our patients and quality of life for our clinicians. Thank you.
Lorna, great job. This is Tom McKenzie from Denver Health. I have a few questions that have been submitted from the panel members. There were a couple of questions about the balance of OPAT patients on vancomycin and those who are not on vancomycin. Do you have a sense for what % of all the OPAT patients go home on vanco, and would you have separate pathways for those on vancomycin versus other patients?
Sure. So thanks for having me. The last year worth of vancomycin data that I pulled on this specific question was from 2019, so sort of pre-pandemic numbers. But in that year, we DC'd about 1,000 patients on OPAT, and 175 of them were DC'd on vancomycin. So it is a small proportion overall, but my larger vision for this project is that eventually this would be applied to all patients discharging on any IV antibiotic. So initially it'd be rolled out as a pilot project targeting vancomycin specifically, and then eventually would hopefully positively impact all of those patients discharging on OPAT.
Great. My second question is around whether you know if this intervention or type of intervention has been in place at any other EPIC institutions. We have an OPAT service here at Denver Health, and I don't know whether this kind of thing exists here, but have you been able to query any other EPIC institutions to see what they have done?
That's a great question, and I'm in the process of doing that now. I'm talking to an Epic implementation specialist at Epic headquarters, and luckily have found that this functionality is possible and available. I believe it has been implemented in Seattle, and so my goal is to hopefully get in touch with some of the providers there that have already been using this workflow. But I'm certainly heartened by the thought that it's possible to implement this from an Epic standpoint here at our local institution. And my next steps would be to present this to our local Epic project team in order to import these changes.
Great. Thank you, Lorna. Do I have time for one more question, moderator, or are we out of time?
Yeah, you have 1 minute and 30 seconds left.
Oh, great. One other question that came up was around whether you have any, you foresee tracking any balancing measures for this project?
Sure. So one thing I want to be really mindful of is that OPAD is used differently across the system, and certainly other institutions have different workflows. So I am in touch with OPAD programs in Northern Colorado and would plan to be in touch with other OPAD programs throughout the UC Health system to make sure that they don't have any negative impacts by the workflow changes we implement here at Anschutz. And the other piece is just making sure that there isn't any increase in provider dissatisfaction with the workflow. So getting sort of pre and post surveys of provider approval of the process.
Terrific. Thanks so much for your responses and for your energy around this project, Lorna. Great work.
Yeah, thanks.
Great. Thanks, Dr. McKenzie. And then now there's an opportunity for the audience to vote. And so please vote on this project. Great. Thank you. So next we'll move to our next Shark Tank finalists. This will be a presentation from Drs. Tozier, Chow, and Sullivan, Sickle Cell Disease Inpatient Care Improvement Project.
Feeling prejudged, their pain invalidated, neglected, like nobody cares. These are quotes from a study performed by Dr. Amira Del Pino Jones and Casey Bowden, quotes from patients admitted to our own hospital with acute pain episodes related to sickle cell disease. Currently, a person with acute pain episode will flow from clinic or the ED to the observation unit, then the hospital floor, then discharge with care provided through incomplete pathways and order sets. And often their management does not conform to society guidelines with pain control that can be provider-based rather than patient-focused. For a person from this historically marginalized population, suboptimal care leads to dissatisfaction, frustration, and often mistrust of the medical community. For the hospital, it leads to increased length of stay, readmission, and increased cost. We can do better. For the past 6 months, a multidisciplinary team of hospitalists, outpatient providers, nurses, hematologists, pain specialists, pharmacists, emergency room providers, care coordinators, and social workers have been meeting to start developing comprehensive care models and treatment that follow society care guidelines and specific order sets, while also developing personalized pain plans and follow-up for patients with frequent presentations. We also plan on education sessions and materials for inpatient providers and nurses on optimal multimodal care for patients with acute pain episodes. These interventions can easily lead to a win-win for patients and the hospital, providing equitable and effective high-value care, decreasing length of stay and readmission rates by implementing evidence-based protocols to decrease variation in practice. Our goal is to increase the number of patients who receive standardized guideline-based care by 20% through pathways and order sets. We are asking for quality coaching on how to use QI methods to measure our impact. We're asking for project visibility to be able to share our vision and intervention with multiple impacted healthcare groups and leaders throughout the hospital. We're asking for data support, both the optimal statistical analysis and how to best visualize it. And we're asking for training for at least one leader to become an Epic super user and be able to work directly on the order sets. The average inpatient length of stay in our hospital for a patient with an acute pain episode is around 8 days. compared to an expected 3 days, which per year leads to around 550 surplus days that these patients stay in the hospital away from their homes in increased pain. As stated before, our first goal is to increase the number of patients receiving standardized guideline-based care through a comprehensive order set by 20%, with subsequent goals of decreasing length of stay and readmission. We can do better, and we will. Thank you.
Great, thank you. Dr. Habernack?
First of all, thank you for that very engaging presentation. It was, I thought, very, very well done. So on behalf of the panel, I have a few questions for you. The first is, one of the criterion that we use to assess impact is something the implementation scientists might call reach. NIH reviewers often look at significance of a project. How many people are going to be impacted by this? Can you give us some sense for how many patients annually might be subject to the intervention that you've described?
Yeah, hey, this is Michael Terzer, one of the people on our team here. In the initial poll, which included in the initial data poll from the Vizient data for inpatients, that was about 75 patients with actual sickle cell disease over the course of a year. In the course of looking more at this, that's still about 75 patients, probably 100, with about 750 encounters over the last year and a half.
Okay. And then just kind of as a follow-up to that, is the intervention designed for those only who are achieving inpatient status, or for those who might be just treated in the emergency department and let go? Are they going to be involved with this also?
Yeah, so this started as being driven by the inpatient side of things. I'm a hospitalist, but it's really expanded to that as we kind of brought in other stakeholders and recognized that this is kind of a more system-wide issue that we need to address as a system rather than just from an inpatient standpoint. So we do have the ED folks, and they're working on adjusting their pathways as we work on adjusting how we're taking care of people on the inpatient side as well, and also how we work on continuity through ED to inpatient and then eventually to outpatient.
Okay. And how will you measure how well providers are adhering to the pathway you have? What's going to be their fidelity to the way the intervention is carried out? How are you going to make those measurements?
Great question. I'm not sure we have a perfect answer yet. Although this was prompted by length of stay, that's obviously not, where we're focusing, or that is a focus, but not how we're going to measure ourselves solely as we move forward here. And as Dr. Sullivan, who kind of did that presentation, mentioned, our focus is on attaining as many of these guideline-based recommendations as possible. So we're going to select ones that we think are we're doing worst on, and also most likely to improve, and kind of select those. So things like low-hanging fruit, like ordering and having incentive spirometry, but also considering things like how quickly pain is improved as we have PCAs ordered and stuff like that.
Good. So patients' perceptions are a big part of this, aren't they? That how patients perceive their care is an important thing that you're trying to improve here. How will provision of a pathway or use of a guideline have an impact on that?
You're very right. So I think the use of a guideline and a pathway isn't the only thing that we need to do to address how patients perceive their care. And we have a lot of work to do there too. But one of the things we've learned as we've talked to patients and kind of reviewed the work that Amira and Casey Bowden have done in the past is that there's a lot of lack of standardization of care that leads to abrupt changes in the way their medications are administered between the ED and inpatient, or inpatient provider to inpatient provider. And that, as we make those switches, leads to mistrust. And as we standardize, our hope is that they will start to trust us more as something that's not going to rapidly adjust and affect their pain in a way that's difficult to manage.
Thank you. Looks like we're out of time.
Great, thanks, Drs. Habernack and Tozer. Again, here is the poll for the audience to vote. Great. So our next project is Project Safest, scheduling ambulatory follow-up for effective and secure transitions. And it'll be presented by Tara Ward and Neelam Mistry.
Hi Sharks, thank you for allowing us to present Project Safest. My name is Tara and this is my colleague Neelam. Let me tell you about a typical day in the life of a hospitalist. You walk into a list of new admissions and medically and socially complex discharges. Mrs. S is discharging today, so you ask your care coordinator to schedule a PCP appointment for medication adjustment and lab follow-up. Unfortunately, the care coordinator could not make the appointment after calling multiple clinics for an open Medicaid slot, despite waiting on hold for an hour. And this was not communicated to the provider team. Mrs. S is discharged without scheduled follow-up and is readmitted 2 weeks later. Unfortunately, this story is not unfamiliar. This is a shared frustration across the board. We are asking for your help to build a standardized process for a safe and successful transition for our patients. This is a pervasive problem nationally. Patients suffer from the negative impacts from poor transitions of care. Patients are discharged quicker and sicker from the hospital. The discharge time is a particularly vulnerable time for patients at risk for complications related to their care. There's a general consensus that timely outpatient follow-up within 2 weeks of discharge is beneficial, with some studies showing a reduction in readmissions and costs.
Preliminary data from October 2018 to December 2020 shows that the Division of Hospital Medicine cared for about 18,000 patients, 33% of whom had Medicaid. Of those, only 55% had PCP appointments scheduled within our system prior to discharge, with only 16% of those with follow-up within 30 days. Medicaid patients are below the federal poverty line, which already places them at a higher risk for poor health outcomes, which is why we are choosing to focus on this specific demographic. Therefore, our aim is to increase the percent of Medicaid patients discharged with the scheduled appointments within 14 days of discharge by 15%. There are multiple stakeholders involved in the discharge process, each facing their own unique inputs and barriers. Unfortunately, there's significant variation in the current processes to secure appointments. This lack of standardization creates miscommunication, delays, and missed opportunities. This is a big source of dissatisfaction among all.
Our vision for change is broken down into 2 parts. Over the next year, our first intervention will focus on identifying and implementing an ideal workflow and communication between providers, care coordinators, and patients. Our primary outcome measure will be to monitor the number of PCP appointments made prior to discharge. Our secondary measures will be to monitor ED visits and readmissions within 30 days, stakeholder satisfaction, and adherence to appointments. We are asking for project management and data and analyst support. We will build on this work on our second phase, focusing on standardizing discharge workflows and building partnerships with ambulatory clinics to optimize transitions of care. As we grow our project, we anticipate needing Department of Medicine leadership and support to improve access for all patients. The impact of our work is to improve patient experience and safety during transitions of care, and we need your help. Thank you for your time.
Great, thank you. Dr. Weiler?
Yes, thank you for this excellent presentation and identifying what is obviously a large and important problem. The panelists had a couple of questions for you. The first is, will this work tie into the hospital transformation project, which is asking our institution to improve outcomes for Medicaid patients and to create community partnerships?
Thanks, Dr. Weiler. I'm happy to answer that question. So that was definitely a big part of why we started this project, just knowing kind of anecdotally on the front line what happens and the issues we run into, as well as knowing that for the HTP or Hospital Transformation Program, that it might be one of their metrics that UCH will be looking at. That's why we really jumped on this project and thought it would be super important, not only for us locally, but as a hospital system as a whole.
Great. The next question is, in your pre-work assessment, do you believe that this is a workflow issue in terms of barriers or ultimately a resource issue, so availability of appointments?
I can take that one, Tara. Thanks, Dr. Weiler. So I think it's a bit of both. I think the larger grand scheme is an access issue across the system for us and also across just our community partners in terms of availability. But there from our initial assessment of how care coordinators and providers talk to each other, talk to outside systems, there's a lot of redundancy in terms of multiple care coordinators are calling the same clinics to get the same information, yes or no, on clinic availability. There's also a lot of variability in closed loop communication between providers. And so before we, like in our project, before we jump onto phase 2, and we're actually going to be working on this simultaneously, increase our community partners. We're also trying to get stuff figured out at home and improve the process for getting to these appointments and provider communication, care coordinator satisfaction as we move toward increased access in the future.
You described your primary outcome measure for phase 1 in follow-up of 7, 14, and 30-day appointment times specific to primary care follow-up. Are these 3 different outcome measures the panelists want to know? And how does that tie into your projected goal of a 15% improvement?
Thanks, Dr. Weiler. So they will be 3 separate outcomes that we look at. Unfortunately, right now with our prelim data, there's not really a way to differentiate between who falls into just 7 versus who is also lumped into 14 and 30 days. What we do know right now is that our 30-day readmission rate for Medicaid patients in our system alone is almost 19%, and same with the ED visits, about 19%. And so we're hoping that we can improve the, we'll be looking at 7, 14, and 30 days, but right now, unfortunately, we only have the ability to discern specific patients for that 30-day follow-up. So our outcome, the measure where we want to improve the percent, that is going to be specifically for the percent of appointments scheduled, which we are going to be using as a surrogate, hopefully in the future, to see if how that moves the needle for readmissions and ED visits. But as everyone knows, readmission rates and ED visits after hospitalizations is a complicated thing with many different factors. And so this is one of the pieces that we're looking to move to help move the needle for some of those larger factors.
Thank you.
Great, thanks, Dr. Weiler. So now the audience can vote.
No.
So our next project is Laboratory Stewardship, the right test at the right time. And this project will be presented by Dr. Rudolphiker and Dr. Saccone.
Good afternoon, everyone. I have the pleasure of presenting a high-value care inpatient lab stewardship initiative with Dr. Eric Rudolphiker. It isn't a secret that we check too many lab studies on patients while in the hospital. Unnecessary laboratory studies make up a large percentage of wasted healthcare dollars in the US today. Many factors contribute to this pervasive problem in medicine. First, as demonstrated here, we are all immersed in a culture of medicine that thirsts for objective data. There's also concerns voiced from residents that their attendings want labs daily and that it's better to just have labs to be on the safe side. Furthermore, at times the cognitive load on residents as well as attendings is so high by the end of the day that reflexively ordering labs is the safest path at the end of a long workday. It's been about 10 years since the ABIM came out with their Choosing Wisely initiative. And in that time, multiple organizations have come out against daily lab orderings in the face of clinical and lab stability. We want to make this happen at both Denver Health and University Hospital in the next year.
So imagine a world where hospitalized patients undergo fewer venipunctures, cost savings, not thinking so hard about whether a patient needs labs, less hospital-induced anemia, shorter presentations on rounds, and happier patients. This is Denver Health. This exists as a result of some of the interventions that we've put in place there over the last 2 years. We've done design thinking workshops with residents. We've implemented nudges into the EMR and thought about how to reduce cognitive load to improve lab ordering. And that's resulted in reductions in CBC and BNP ordering by over 25% over that time period. Here's some of the examples. We have a BPA that shows up when your patient had normal labs yesterday and you try and order them again, suggesting that maybe they don't need them. And we restricted repeat labs to 24-hour periods at a time. We've addressed some of the culture piece by implementing high-value care noon conferences with residents and engaging attendings in conversations about this initiative. We plan to expand these interventions at Denver Health and also to share the lessons learned and some of these best practices and put similar interventions at place at University of Colorado Hospital. We also, in the works, have additional tools to help reduce cognitive load, like this morning lab ordering panel that displays the patient's yesterday's labs. Well, that's it, Sharks. Thanks so much for listening to our presentation, and we hope you choose our project.
Great, thank you, team. Dr. Kumbler?
So really fantastic presentation and very exciting, but our sharks have a number of questions for you. The first one relates to cognitive load. And you talked about the concept of reducing cognitive load, but some of our sharks wondered whether the BPA and needing to process additional information prior to ordering morning labs could actually increase cognitive load. The flip side is not needing to process the results of those unnecessary labs will decrease cognitive load. Help us to understand if you plan to measure cognitive load, and how will we know whether your interventions in some have made it easier or harder to be a doctor within these hospitals?
Thanks for that great question, Dr. Kumbler. If cognitive load was easy to measure, we would do it. Unfortunately, it's not. It involves really talking through processes with residents and providers. One of the things that they decided was that they go on autopilot, clicking and ordering labs at the end of the day because they're tired thinking of other things. And that's where we came up with the idea of the AM order panel, which would not only make it very easy and way fewer clicks to order morning labs for your patients, but also simultaneously display the patient's previous labs next to them. So you have information in front of you instantaneously to make a quicker, smarter decision.
Very good. Our next question from the sharks is especially toothy. You mentioned that reducing unnecessary laboratory testing was at the intersection of the structures you put in place through the electronic health record and the culture within the organization. What do you expect any cultural differences between Denver Health and the University of Colorado Hospital? And if so, how will you uncover that and address them?
Another great question, because culture change is so hard, and it all starts with the burning platform, which is just making this problem known to all the providers at both sites. I think all of our providers at each site are committed to high value care. And I think this is a unique project that the university can connect these two institutions and really push for a culture of appropriate utilization of resources.
Very good. Our last question relates to scale and scope. Do you see, after rolling this out at University of Colorado Hospital, taking it back to Denver Health to expand further? Do you imagine this being located at just the University Hospital or across all of UC Health?
I think you're muted, Dr. Sarkon.
So the last question relates to scope and scale.
I was muted talking.
Okay.
I double muted myself. Sorry about that. So I think the idea with this project is that we would like to not only expand our reach at Denver Health, but also engage in crosstown collaboration with the university and their affiliates, if they so choose for the affiliates to essentially share lessons learned as we continue to roll things out at Denver Health, get ideas as well from our colleagues at the universities, and really try to come up with a crosstown high-value collaboration between the two institutions.
Beautiful. On behalf of all of the Sharks, thank you for your work and your wonderful presentation.
Thanks.
Great, thanks, Dr. Kumler. So now we'll have the audience poll again. So our final project is increasing advanced care planning in specialty ambulatory clinics, and Laura Peters will be giving us the presentation.
I'm Laura Peters, and I'm a nurse practitioner with the Advanced Heart Failure team. My quality improvement project is focusing on integrating advanced care planning into ambulatory specialty clinics. But first, I want to start with a story. At 54 years old, my mom was diagnosed with stage 4 pancreatic cancer. No one in my family was prepared. In a matter of days, the oncology office arranged several tests and a day-long meeting with many specialists. I noticed that one was missing. Despite all the support of the oncology office and the fact that my mom was facing a terminal illness, she was not offered palliative care. Through the friends, we were connected with an incredible palliative care doctor, and with this doctor, we were able to have meaningful conversations about what my mom wanted the end of her life to look like. The COVID-19 pandemic has highlighted the urgency of individual preparedness planning through advanced care planning. Despite being a national priority, advanced care planning is underutilized in the general care of patients, even those with a chronic illness, and have high risk for mortality. Advanced care planning assists to help align medical care with patient goals of care, as well as inform caregivers of patient wishes. Given the importance of advanced care planning, this quality improvement project will focus on integrating advanced care planning in 2 specialty clinics that follow patients with a chronic illness who have a high risk of mortality. Specific goals include increasing MDPOA completion and uploading these into the electronic health record, increasing the number of advanced care planning conversations, documenting these conversations in the new Advanced Care Planning Navigator in the electronic health record, and billing for these conversations. This project will partner with the UC Health Extraordinary Partners in Care initiative with the goal of annually assessing and documenting goals of care for every person who receives care through UC Health. The University of Colorado Hospital is using advanced care planning champions to promote this initiative, and there are multiple team members on this project who are also advanced care planning champions. Advanced care planning is hard and can be time consuming. Assistance from the Quality and Safety Program would provide department support and clinician time for this initiative. It would provide innovative ideas for efficient advanced care planning and resources to partner with UC Health and support our clinics in this important endeavor. The advanced care planning discussions surrounding my mom's diagnosis and wishes were heart-wrenching, and yet, because of these conversations, we were able to be intentional and make some wonderful memories. She had goals she hoped to live long enough for, and when she met those, she chose to stop her chemotherapy. We were able to honor her wishes by personally taking care of her so she could die peacefully in her home. We can't keep everyone alive forever, but we can provide control, meaning, and a sense of purpose in the last days of someone's life. I miss my mom every single day, but I will be forever grateful for the intentional time we had with her at the end of her life. I am also so grateful she was willing to voice her wishes so that we could honor them. This is the gift I want to pass on to others. I want to integrate advanced care planning so that patients can live well and die well.
Great, Dr. Glasheen.
First of all, Laura, thank you for your presentation and for that very poignant story and personalizing it and for being vulnerable with us today. It really does drive home the importance of this work. Question about from the panel about what do you think some of the initial barriers would be to this project, and how do you think about overcoming those barriers?
The biggest barrier in our initial work has been time and understanding how to use some of the resources that EPIC now has. So I think really focusing on creating efficient advanced care planning and using interventions that work well with specific clinic workflow. So specifically for advanced care planning in the heart transplant clinic, we are focusing on MDPOA completion. It's fairly simple, and a lot of our patients use My Health Connection. So we're trying to use the tools that we already use and add an intervention that won't take up a lot of time. I think really focusing on making this something that works well in clinics is going to be very important.
And have you identified the clinics that you would like to do this work in?
Yeah, so this again, like I said, is a system-wide initiative, and it's being pushed through ambulatory advanced care planning champions. So for this kind of pilot project, we've picked the heart transplant clinic as well as the COPD clinic. They follow two different types of patients and also have different resources. So we thought that having the variety along with a patient population in both clinics that has a high risk of mortality, it would give us a unique perspective in two different places.
Excellent. And do you have baseline data within those clinics about how often ACP is currently done?
So we don't have a lot regarding advanced care planning, mainly because it's challenging to get. So we have some baseline data regarding MDPOA completion. It's less than 45% in the heart transplant clinic and less than 25% completion in the COPD clinic. We do have the availability to pull billing and see who has billed for that. It's very low, almost nothing in both clinics. So a large room to improve, hopefully.
Excellent. And as we think about the potential for improvement, do you have a goal in terms of your aim statement in terms of what type of improvement you would like to see in those two clinics?
Yeah, so the overall system-wide goal would be to increase MDPOA completion by 4%. We hope to be much more upwards of 25% or more for MDPOA completion. We currently hope to also increase advanced care planning conversations by 5%. So the documenting of the conversation as well as billing for that conversation.
Excellent. So when you say 4% overall, that's an absolute increase, not a relative increase?
Correct.
And you'd be shooting for more like a 25%?
Yes. But that might be a little ambitious.
Well, it's an important area to be ambitious about. So Mike, I'm just going to say Laura did such an amazing job. She got through all of my questions with 35 seconds left to go. So congratulations on that, Laura. I'll turn it back over to you, Mike.
Great. Thanks so much, Dr. Gosheen. So here is the audience poll. So now the sharks will deliberate and choose the talk about the projects.
Today I'm speaking on behalf of the cardiology fellows in the University of Colorado Hospital Clinics, the Wednesday and the Thursday team leaders, Heather Hallman and Kylie Ademic. These individuals collaborated in the execution and data analysis for our heart failure radar initiative, which was designed to reduce complications and augment LV recovery for new heart failure patients. Early follow-up is a necessary objective, but it's not sufficient to reduce mortality and readmissions beyond 30 days. We hypothesize that the timely achievement of optimal molecular therapy will improve outcomes because at the time of heart failure readmissions, registry data has shown that over 50% of patients are not on optimal medical therapy. In order to institute high-value care for patients who have heart failure with reduced ejection fractions, we need to improve outcomes and reduce complications. We enrolled the patients that had a recent diagnosis of a heart failure, reduced ejection fraction at the time of their first MD visit. Typically, these were patients had been admitted and had new diagnosis of heart failure on the inpatient services. And we set up heart failure radar dashboards, which included patients that were from all providers as well as it could be set up for individual providers. And our intervention was designed to try to advance book about 2 to 3 visits for the heart failure patients in order for us to meet their optimal medical therapy goals within a 6-month time period, because sometimes the time to the next available appointment is too long to accomplish an efficient titration schedule. We also set up Epic Smart Lists in order to schedule follow-up and set optimal medical therapy goals for individual patients. And also had some educational instruction that could be imported into the visit summary to give people background information about the illness. And finally, we coordinated some assistants in the clinic, the medical assistants agreed to help book 2 to 3 appointments in advance for the heart failure patients, and also to prevent the visit summary and make sure that they had that when they left the clinic. We followed a very practical timeline for med titration. During this study, the cost for Entresto became more affordable to many patients and was initiated earlier and without the 12-week transition period that was typically allotted for ARNI titration in the past. Thus, ACE, ARB, or ARNI were readily established within our proposed 6-month timeline. Here are some examples of the smart lists that we use to schedule the follow-up visits and to insert patient instructions in the visit summary, and also into the note to communicate med titration plans with the other providers and nurse practitioners in the clinic who are helping us with the med titration for these patients. We targeted an enrollment of about 150 patients, assuming there'd be 2 to 3 per fellow per month over a 6-month period of time. However, we didn't accomplish this enrollment goal. First of all, I overestimated the number of recent heart failure patients that will be booked in the clinic. And since new heart failure referrals are distributed among all general cardiology providers, only about 25 or 30% will be coming into the fellows clinic. So in order to reach a power for an effect on a readmission rate, we're going to need to continue to enroll heart failure patients in the upcoming year, which is our current plan. Our enrollment numbers were also impacted by COVID. Publications have shown that fewer acute MI cases were admitted to the hospital, and that's shown at the UCH database here with purple bars. There's similar reductions are also seen for inpatients with acute and chronic systolic heart failure codes displayed as the red, green, and blue bars. So this affected the total heart failure admissions to UCH and translated to reduction in available patients that could be enrolled in the clinics. This is a list of the high value care metrics that we set up. First is to accomplish a time to optimal therapy within 6 months and using 3 classes of heart failure medications. This is including ACE, ARB, or ARNI and Entresto. And for beta blockers, either metoprolol 100 milligrams or greater doses once a day, or carvedilol 25 milligrams twice a day. And thirdly, the category of either spironolactone or dapagliflozin, which has been approved for heart failure indications. We also wanted to measure the percent of patients that were on optimal therapy by 6-month time frame and compare this data from the baseline to the current intervention year. And measure the objective, which is improved left ventricular ejection fraction recovery. That was determined as the ejection fraction change between the echo at the time of diagnosis, which usually occurred in the hospital setting, and then a follow-up echo when the patient had been started and optimized on maximally tolerated heart failure medications. And finally, trying to calculate the readmission rate over a period of time, 1 year after the original diagnosis, requires access to other databases in order for us to count admissions to other hospital networks in this region. Our results here are shown for the metrics that pertain to accomplishing optimal medical therapy. The heart failure, the percent of the patients that were on 2 or 3 heart failure meds were similar between our baseline and the heart failure radar groups. However, the heart failure radar group included a significantly greater number of patients who accomplished optimal medical therapy within the 6-month time frame. And they did this with a reduced mean number of days compared to the baseline cohort, 164 versus 267 days. And finally, more patients in the heart failure radar group were on 3 meds and had higher average optimal medical therapy scores. The follow-up echoes showed improved ejection fractions with optimal therapy in both the baseline and the heart failure radar groups. However, we still are waiting 9 echoes to be done on our enrolled patients with the radar intervention in order to complete the final index of this change. An interim analysis with current patients showed, however, that the EF change was greater in the heart failure radar group compared to the percent change in the baseline group. There was also an increased percentage of the patients that were on Entresto. But interestingly, we looked at the number of days between the time from when the patient had their first echo, which often corresponded to their admission, and the time of their first appointment with a medical provider, with the MD provider in the Fellows Clinic, was 51 days for the heart failure radar group versus 20 days in the 2019 patients seen and included in the baseline group. There are multiple factors that can account for that, but we did experience a number of patients which were hesitant about returning for follow-up visits during this COVID epidemic period. The impact of the heart failure radar program can be assessed through periodic self-review of the heart failure dashboard patients. This is a way that we can identify heart failure patients that were lost to follow-up and also monitor what their current therapies are. It can also improve the performance of individual providers because they can do self-review of their current patients relative to patients that they saw in their prior year of practice. We also observed that there can be heterogeneous performances among providers. So having self-feedback on the advancement of the patients and accomplishment of optimal medical therapy can have goals to improve the implementation of those practices in a setting, in a group setting. Our future goals will try to enroll, we'll continue to enroll patients for heart failure in the Fellows Clinic, and also to improve the duration of time between the time of diagnosis with the first echo and the first follow-up visit with a general cards provider. The high-value care goals for heart failure can be summarized from 4 different perspectives. From the physician's perspective, it can improve the efficiency of their practice. It can expedite follow-up visits for high-priority heart failure patients, and can communicate the goals and also the indications for medications, which can improve patient understanding as well. There's goals from the patient's perspective that they can acquire better education about their illness and also learn about high priority medications that are designed to improve their heart function. And this can have outcomes which improve patient adherence to medications, as well as participation in home monitoring for fluid and weight changes. Ultimately, the purpose of heart failure therapy is to try to improve EF recovery. And this can translate to better quality of life and better outcomes for the patients, including reduced medication costs and reduced costs for additional procedures such as ICD placement if their EF does recover over 35%. And finally, to be determined, we can look at the impact of the program for the number of readmissions to the local hospital as well as regional hospitals in the area. which is our current plan. I'm unable to attend this presentation, but you can please feel free to send me questions and comments via email, and I will address those. Thank you for your patience.
All right, looks like Dr. Ho might be having some difficulty rejoining. So this is Heather Hallman, the quality manager. I will take over from here. Just as a refresher to everyone, the winning project will receive quality coaching, project management, data collection, and access to our EPIC analyst, prioritization and high visibility, and stakeholder support for 1 year. Homer, next slide, please. All right, and pretend you hear a drum roll. The winner is Lorna Allen for her vectors, vancomycin errors corrected through optimizing OPAT med reconciliation and AVS standardization. So thank you so much for our judges choosing her. Laura, we have about 2 minutes if you'd like to say a couple words.
Wow, well, I'm taken aback. Thank you so much. I did not expect this, but I guess I would just first like to especially thank all the mentors that have helped me with this. Dr. Brian Montague, Dr. Corey Hussein, Dr. Larissa Pisney have all been really important in getting this project off the ground. And I'm really excited to continue working on this. And hopefully in a year, I'll come back to you with some great outcomes data. And thank you so much for picking this.
Thank you, Lorna. Last slide, please.
So is it a big deal if?
Well, thank you everyone so much. Thank you to our finalists and judges for their hard work in doing this. Oh, looks like we have Mike back. I'll let him do the closing words.
Oh, no, thanks. Congratulations, Lorna. I wanted to thank Heather Hallman and Homer Atanasio for, setting this up and, making this event happen. I can't thank the judges enough for doing this. And again, congratulations to all the finalists. These were great projects. And I hope you guys continue to work on these, and our team will be contacting you to see if we can help in any way possible. So thank you, and again, congratulations to Lorna. Take care.